Okay, so you know that feeling? You spend, I don't know, half of Sunday afternoon mapping out this perfect CBT session. You've got the thought record ready, the Socratic questions are just chef's kiss. You're ready to collaboratively dismantle some cognitive distortions.
Oh, I know exactly where this is going. I can feel the punchline in my bones.
Right? And then your client walks in and you can just see it. The storm. Their nervous system is completely hijacked. They're not just anxious, they're in a state of, profound emotional dysregulation. And your beautiful, logical thought record, it might as well be written in another language. It's just useless in that moment.
Absolutely useless. And in that moment, you're not a CBT therapist anymore. You're just a human with another human trying to find an anchor, anything to hold on to.
Exactly. This episode is adapted from a clinician-written article on Mentalyc and brought to life in audio for therapists who prefer listening on the go.
And this piece was written by Adesua Olagira L., CP, and we're really excited to feature their perspective here.
Yeah, it's a great piece. And for anyone who might be new to us, since the article comes from Mentalyc, it helps to know it's a platform designed to make clinical documentation more manageable for therapists.
Which, speaking of that feeling of your session plan going out the window, that's exactly when the documentation gets complicated, right? Because your note has to somehow explain that pivot.
The pivot, the eternal pivot. It's this constant dance, isn't it, between structure and chaos? Or maybe a kinder word is fluidity. We have these incredible evidence-based tools, CBT and DBT being two of the heavy hitters, and they're not interchangeable, not at all. But in the room with a real person, the lines can feel so blurry.
I think that's the core of it. We learn them as these distinct, separate modalities in grad school. CBT is for thoughts and behaviors. DBT is for emotion regulation and crisis. Box A, box B. But people don't come in neat boxes. They come in as a tangled, beautiful, messy combination of everything.
Tangled, beautiful, messy combination. I love that. It's so true. You have a client with classic social anxiety, a textbook CBT case, right? Avoidance, catastrophic thinking. You're thinking, great, we can do some cognitive restructuring, some behavioral experiments.
Yep, you're already picturing the exposure hierarchy in your head. Step 1, make a phone call. Step 2, go to the grocery store. It's all laid out.
But then you realize their fear of judgment isn't just a distorted thought. It's tied to this profound, deep-seated fear of rejection that sends them into a shame spiral. And when they get emotionally activated, they can't access that logical part of their brain that CBT speaks to. The part you need for a thought record is just offline.
It's completely offline. The prefrontal cortex has left the building. And you're left with the limbic system. And the limbic system does not care about your beautifully crafted Socratic questions. It cares about survival.
Exactly. So the clinical question becomes, what does this person need right now? Do they need to challenge a thought? Or do they need to learn how to survive the emotional wave without drowning?
And that, I think, is the fundamental difference. CBT is teaching someone how to rebuild the boat. DBT is teaching them how not to drown when the storm hits. You can't exactly rebuild the boat while you're gasping for air.
Whoa! That's a perfect metaphor. Seriously. Because it implies the sequence, right? You need the distress tolerance, the mindfulness, the emotion regulation skills, the core of DBT, before you can even begin the cognitive work. You need to get them back in the boat first.
Or at least give them a life raft. You know, a tip skill or some radical acceptance. Something to get them through that moment of intensity. Because if a client's window of tolerance is incredibly narrow, any attempt at cognitive challenge or exposure is just going to push them right out of it. It can even be re-traumatizing.
Oh, 100%. And then they feel like a failure, you feel like a failure, and the therapy stalls. They say, see, I can't even do this simple worksheet. I'm broken. When the reality is, it wasn't the right tool for that specific moment.
It's like handing a hammer to someone who needs a screwdriver. The hammer is a great tool, but it's not going to work here. And I think that's where the clinical art comes in. Knowing when to put down the CBT hammer and pick up the DBT screwdriver. Or maybe it's a wrench. I don't know, my metaphor is falling apart.
No, I'm with you. It's about having the whole toolkit and not being dogmatically attached to one single tool. I had a client, let's call her Sarah. She came in for panic attacks, which is prime CBT territory. We started working on identifying triggers, challenging catastrophic thoughts about having a heart attack, the whole 9 yards.
Makes perfect sense.
It made perfect sense on paper. But when we tried to do interoceptive exposure, having her spin in a chair to induce dizziness or breathe through a straw to simulate shortness of breath, it was a disaster. She wasn't just anxious. She was terrified, full-blown panic, dissociation. She couldn't stay present enough to learn that the sensations weren't dangerous.
The exposure wasn't creating habituation. It was creating overwhelm.
Total overwhelm. And I had this moment of, what am I doing wrong? And then it hit me. The problem wasn't the exposure. The problem was that she had zero skills to manage the distress that the exposure was supposed to generate. We had skipped a step, a huge step.
The DBT step.
The DBT step. So we paused everything, all the CBT work, and we spent the next several weeks just on distress tolerance. We practiced the 4-7-8 breathing mentioned in the article, but also things like using ice packs to intense sensations, the TIPP skills. We did mindfulness exercises to help her notice the panic rising without merging with it. We just focused on building her capacity to be with intense feelings.
You were building a life raft. You were showing her how to ride the wave instead of being crushed by it.
Exactly. And it was slow. And for a while, from a documentation perspective, it probably looked like we weren't addressing the presenting problem of panic attacks. My notes shifted from challenged cognitive distortions to practice distress tolerance skill of temperature change to reduce physiological arousal.
And that's such a critical piece for auditors, for insurance. You have to be able to articulate the clinical rationale for that shift. Why are you suddenly working on distress tolerance when the diagnosis is panic disorder? It's about connecting the dots.
Connecting the dots is the whole game. And honestly, that's where I have found tools that help with documentation to be so clarifying. When I'm working on a treatment plan, for instance, something like the Mentalyc AI treatment planner helps me frame it properly. I can create an objective like, client will increase capacity for emotional regulation to facilitate engagement in exposure therapy.
Oh, that's good. That's really good, because it explicitly links the DBT-oriented skill building to the longer-term CBT goal. You're not just doing random skills, you're building a foundation.
Right. It helps me show my work. The intervention isn't just practiced mindfulness. It's utilized mindfulness of current emotion to decrease experiential avoidance in preparation for graded exposure. It tells the story of why I made that pivot with Sarah. It demonstrates that the shift was a deliberate, clinically necessary step, not just me throwing spaghetti at the wall.
We've all had our spaghetti throwing moments, let's be honest, but being able to document it coherently, that's what elevates it from guessing to strategy. And after you built that foundation with Sarah, what happened when you went back to the CBT work?
It was night and day. We went back to the interoceptive exposure, starting really, really small. And when the dizziness started, instead of panicking, she'd say, okay, this is a sensation. I'm noticing it. I'm going to grab my cold pack. She had an anchor. She could stay in her window of tolerance long enough for the learning to happen. The cognitive work could finally land.
That's what it's all about. It's not CBT versus DBT. It's about the right tool at the right time for the right reason. And often it's a sequence. DBT first to stabilize, CBT second to restructure.
It really is. It's about assessing the client's core deficit. Is the primary problem the maladaptive thoughts, or is the primary problem the inability to tolerate the emotions that those thoughts trigger?
That's a great way to put it, and it applies to so many things beyond panic. Think about OCD, depression, trauma. With depression, for example, CBT is fantastic for behavioral activation. Let's schedule one pleasant activity this week.
A classic, effective intervention. But what if the client is so mired in hopelessness and self-loathing that the idea of a pleasant activity feels like a cruel joke? What if their emotional pain is so intense that getting out of bed is a monumental task?
Then behavioral activation isn't the first step. The first step might be radical acceptance of the current pain. It might be a mindfulness skill to just notice the texture of the blankets, to ground them in the present moment, instead of being lost in a vortex of future hopelessness. It's the being before the doing.
The being before the doing. I love that. DBT gives us the language for that being part. Mindfulness, distress tolerance, emotion regulation. It validates the client's experience. This is incredibly hard. It makes sense that you feel this way. Let's just focus on getting through this minute.
That validation is so key. CBT is very change-focused, and that's powerful. But if you try to force change on someone who doesn't feel seen or understood in their suffering, it can feel incredibly invalidating. DBT brings in that dialectic, acceptance and change. We accept where you are, and we work towards change.
It's the core dialectic, and it really changes how we approach documentation, too. A good CBT note might say, client identified the cognitive distortion of all or nothing thinking and generated a more balanced thought. That's measurable. It shows progress.
Clear, concise, perfect for insurance. It checks the box.
Right, but a good DBT note might say, client was experiencing intense shame and, using a mindfulness skill, was able to notice the emotion as a wave without engaging in self-harm. That's also measurable progress. But the goal isn't cognitive insight. The goal is safety and stabilization.
And that's a huge win. Averting a crisis behavior is progress. It's life-saving progress. But sometimes I think we as clinicians get so caught up in the pressure to show cognitive change that we forget that regulating the nervous system is a valid and essential therapeutic outcome in itself.
Totally. If this kind of reflection is useful, Mentalyc helps. Its AI treatment planner and note writing features support your documentation process and stays fully HIPAA and SOC 2 compliant. You can explore it at Mentalyc.com.
And I think there's a deeper dilemma here for us as therapists. It's this pressure to be effective, which often gets translated into getting quick results. CBT, with its structured short-term models, looks great on paper for that. You can map out a 12-session plan to resolve social anxiety.
Yeah, and there's this unspoken feeling sometimes that if you have to switch to DBT skills, you're going off track, or that the treatment is going to take too long. It can feel like you're failing at the real therapy, which you've defined in your head as the cognitive work.
Exactly. There's this internal narrative of, I should be able to do this with CBT. That's the gold standard for this diagnosis. It's almost a sense of clinical shame, like I'm not skilled enough to make the CBT work.
Yes, that's it, exactly. It's not about the client failing at the worksheet. It feels like I'm failing the client. But reframing it has been so liberating. Realizing that recognizing the need for DBT skills isn't a failure of my CBT skills, it's an attunement to my client's actual needs. It's a more advanced clinical skill, actually.
Attunement, that's the word. It's listening to what the client's nervous system is telling you, not just what their words are saying. Their nervous system is saying, I'm not safe enough for this yet, and our job is to listen to that. And it's hard because DBT work can feel less linear. Progress isn't always a straight line up.
Not at all. It's 2 steps forward, 1 step back. A client might use a skill perfectly one week and then fall back into old patterns the next. The documentation needs to reflect that reality. Clients struggled to use skills this week due to external stressors, and we focused on chain analysis to understand the breakdown and problem solve for next time.
Right, which is a core DBT intervention, the chain analysis. It's not about judging the failure to use the skill, it's about getting curious about the chain of events that led to the problem behavior. It's a data gathering process, not a moral failing.
And this is where the two modalities can start to look similar on the surface, but their function is different. A CBT thought wrecker and a DBT chain analysis are both forms of tracking. They both link triggers to outcomes, but the focus is different. The thought record is laser-focused on the cognitive distortion. The chain analysis is looking at the whole picture: vulnerabilities, triggers, links, behaviors, consequences.
It's a much wider lens. It's less about what was the faulty thought and more about what was the entire context in which this behavior made sense. It's a fundamentally more compassionate and less pathologizing stance, I think, especially for clients with trauma histories or significant emotional dysregulation.
I agree. It honors the idea that the behavior, however destructive, served a function. It was a solution to an unbearable problem, even if it was a terrible solution. Our job isn't to shame them for that solution, but to help them build better ones.
You know, something that's shifting for me, even just in this conversation, is that I've always thought of it as a clear hierarchy. You do DBT, you graduate, you do CBT. But listening to you talk about Sarah, it feels more like a dance.
Dance? Tell me more about that.
Well, it's not like you finish DBT and are now ready for CBT. Life happens. A client could be making great progress with cognitive restructuring, and then they have a major life event, a breakup, a job loss, and their nervous system gets thrown back into that crisis mode. And in that moment, you might need to fluidly dance back to the distress tolerance skills. You put the thought record aside for a session and you pull out the tip skills again.
Oh, wow. Yes. It's not a linear progression. It's a responsive process. You're constantly assessing, where's my client's nervous system today? What tool does today's presentation call for? That's such a more dynamic and realistic way to think about it. It takes the pressure off this idea of a graduation.
Right? The skills become part of their lifelong toolkit. So when they're dysregulated, they know how to use their DBT skills to get back into their window of tolerance. And when they're regulated, they can use their CBT skills to challenge the thoughts that might lead to dysregulation in the first place. The goal is for them to become their own integrated therapist in a way.
To be able to make that assessment for themselves. Okay, I'm feeling overwhelmed. This is not a time to analyze my thoughts. This is a time to breathe and feel my feet on the floor. And then later, okay, I'm calm now. Let me get curious about the story I was telling myself that got me so activated.
That's the ultimate goal of therapy, isn't it? Internalizing the therapist. And that dance, it needs to be reflected in our notes over the long term. You should be able to look back over 6 months of notes and see that dance, see the shifts between skill building and cognitive work and back again. It tells a much richer story of the client's journey.
And proves medical necessity, because it shows you're adapting the treatment to the client's fluctuating state, which is the definition of skilled, responsive care. It's not rigid, it's alive. It's not just about what we do, but why we do it and when we do it. And that when is everything.
The when is everything. And trusting our clinical judgment on that when. Trusting that if your gut is telling you to put down a thought record, it's not because you're a bad therapist, but because you're a good one. You're listening.
That feels like the most important takeaway for me. That little moment of self-doubt we can feel when we have to pivot away from a structured plan, reframing that moment. It's not a deviation from the path, it is the path. The path is listening and responding.
Yes. So maybe the one thing to carry forward is this. The next time you feel an intervention isn't landing, especially a CBT one, pause. Ask yourself, is the issue with the client's logic or is it with their nervous system's capacity? Are they in a place to think differently, or do they first need a tool to help them feel differently? Or
more accurately, to tolerate their feelings without being swept away.
That single question could change the entire direction of a session, and maybe even the entire course of treatment. It's about diagnosing the need of the moment, not just the diagnosis in the chart.
Exactly. It's what makes us therapists and not just technicians.
Yeah, it really is. If tracking those long-term patterns, that dance between stabilization and cognitive change matters to you, Mentalyc's progress tracking does that without the spreadsheet overwhelm.